All right, Salim Rezai here again with another clinical case just to get us kind of thinking. So we'll just say that there's a patient that comes in with a chief complaint of chest pain and shortness of breath. Vital signs initially are a blood pressure of 142/67, a heart rate of 86, a respiratory rate of 16, and an oxygen saturation of 99% on room air. Clinically, the patient doesn't appear to be an extremis, but state that they've had chest pain and shortness of breath for the last 2 to 3 days. The patient ended up getting a CT pulmonary angiogram. And this is one of the key images, and you can see that the left main pulmonary artery has a big clot in it. And you can also see that the right main pulmonary artery also has a big clot in it. There was evidence of right heart strain on both the bedside TTE as well as the CT pulmonary angiogram. Now, I'll tell you that the labs were really pretty unremarkable. So the question now becomes, we have a submassive PE. So how do we go about treating this patient? Do we do anticoagulation? Do we do thrombolysis? Or do we consider something like an ECOS catheter? It's tough because the guidelines can't even seem to agree. So the American College of Chest Physicians say no, don't thrombolyse patients with submassive PE. The American College of Emergency Physicians says there's insufficient evidence, and the European Society of Cardiology and the American Heart Association say maybe in select patients. And I think the last two organizations probably have this right. I think submassive PE is just too big a category to throw everybody into one kind of pathway for treatment. And we've all seen this. We've seen patients like the one I just described where they just don't look that sick, but there is evidence of right heart strain, up to the ones that are just not hypotensive, but they're diaphoretic, they're tachypnic, they just look like they're on the brink of kind of falling off the cliff and becoming a massive PE. Where we draw this line is going to be dependent on clinical experience, the individual patient characteristics, and what we have available to us. So I'll tell you, for this patient that I just described, we went with anticoagulation. And I'm going to go back to this image because I think this is really important to understand. Not all submassive PEs need thrombolysis. There have been multiple studies now looking at both short-term and long-term outcomes, and there is a risk of bleeding with thrombolysis, both full dose and half dose. And there's a lot of people that are closer on the spectrum of segmental or even subsegmental PEs, and they'll do just fine on anticoagulation. In the sickest ones, maybe we can consider thrombolysis, and then the ones that kind of fall in this gray area, and if it's available, we can consider ECOS catheter. So all three of these are options, but it totally depends on where your patient sits on this spectrum to help you determine what you're going to do for treatment. I hope this gets you thinking a little bit about the next submassive PE patient you get. I appreciate everybody who follows along. Please like these videos if you find them useful or you find them helpful, and please share them amongst your friends. And thanks again, and until next time.